Welcome to the 10 o'clock session. As many of you who've looked over the schedule will see, all it says is resident presentations, left it kind of vague and nebulous. For those who've been here in past years, you'll know that we're lucky to have our speakers from our graduating class of our McCady Family Medicine residency who will be coming talking about projects they've been working on, many of them for several years. And they're all topics that I'm really excited to tell you this year are very pertinent to primary care and medicine in general. And I've learned a lot watching them, and I think you're going to enjoy them a lot too. First, I do want to say one thing about our McCady Family Medicine residency. I've been lucky enough to be the associate program director for several years now, and I love working with our residents. But many of you may not know that the McCady Family Medicine residency, our local residency in the Ogden area, has been around since 1971, and we've graduated over 300 residents. Many of them are working and living here in the Ogden area. In fact, if you're any graduates of the McCady Family Medicine residency, will you stand up and be acknowledged? All right, so you can see they make up a large portion of our Ogden surgical community. Many of our board members, past presidents, current presidents, and others have gone through the program. And so there's a very tight-knit connection between the residency and Ogden Surgical. And so I do want to appreciate everyone being here to listen to these projects, these presentations. Just a couple more things besides presenting here at Ogden Surgical. The residents in the residency provide medical care for over 3,000 of our patients out here in the Ogden community. Many of them are uninsured or underinsured. They participate in over 5,000 hospital encounters with patients at McCady Hospital and provide over 1,200 volunteer hours with organizations in our community, especially the local high schools. We calculated up the monetary value of the resident contributions, and annually the residency is providing over $250,000 to the Ogden community in medical services, for free medical services. So definitely it's a pillar of our community, and we're glad to have our PGY3 residents here. We're going to be listening to them they're going to be having short presentations. We'll have 4 presentations in the beginning. Then those 4 will come up and answer questions. Then the following 3 will come up and present their presentations, and they will sit for questions as well. So we'll kind of break it up that way. This year's a little unique, I will mention. We do have a few of our residents who, when you're at this time of your life, there's a lot of other activities going on. So one of our residents is out of state with a wedding for a very close friend. One of our residents is getting married tomorrow. And one of our residents is at the college graduation of her son. And so they unfortunately aren't here, but they have previously recorded their presentation and will be joining us for questions during the question and answer period. But we're going to get started with Dr. Cox, and we'll ask her to come up to the stage.
Thanks, Dr. Madsen. As he mentioned, my name's Savannah Cox, and I am here to get you all thinking about, could we be ending invasive cervical cancer in the near future? So just to begin with, I don't have any disclosures to share, and in a few short weeks after graduation, I will be going to the sprawling metropolis of Holton, Kansas to be back together with my family. And back to the question at hand. So for decades, honestly over half a century since the contributions of Henrietta Lacks in the 1940s, we have learned that early detection and intervention with precancerous cervical cell changes through screening can be effective in preventing progressive invasive cancerous changes. We also are coming up on the 20-year anniversary of FDA approval and widespread implementation of the HPV vaccine, which, as many of us know, is linked to most of the cases of cervical cancer. However, despite these progressions, there are still 13,000 cases of newly diagnosed cervical cancer in our country annually and 4,000 deaths. And in my opinion, this is far too many in a first world country with as many medical advancements as we have. Which got me thinking, why is this still happening? So I don't think that it's terribly surprising of a statistic that over 50% of invasive cervical cancers are found in those who are overdue for their screening. And unfortunately, the rates of screening compliance are actually gradually decreasing over the last few years, especially since the COVID pandemic. Women with difficulties accessing basic healthcare needs are facing more barriers than ever in difficult financial times that can place extra strain on meeting basic housing, food, and transportation needs, let alone preventative healthcare needs. And women that don't face a lot of those challenges, I think a lot of them would still tell you that they're not terribly excited to update their pap smear when that time comes due. The experience for many can be uncomfortable, awkward, invasive, and then there's an additional layer of complexity to those individuals with history of sexual assault or other traumas that may prevent them from even coming into your office in the first place if they know that a pap smear might be a potential thing that you offer to them. So, with that being said, what can we do to make screening less of a barrier and less anxiety-provoking for many individuals? I think we're seeing shifts in other areas of early cancer detection and screening methods. Most of us are familiar with alternative options for colorectal cancer screening in the appropriate population with at-home collection kits and now even some blood tests. So this got me thinking, could cervical cancer screening be moving in a less invasive direction to increase compliance rates among those individuals? And in the last several months to last year, the incorporation of primary HPV testing, I think, is something that could definitely be opening the door for those opportunities. So, speaking of primary HPV testing, I did just want to highlight some of the recent changes in cervical cancer screening guidelines. The American Cancer Society, I'll just highlight one of their recent updates. In 2026, they've now included self-collected HPV testing every 3 years as an alternative option to the prior recommendations. And then for the USPSTF, they just put out a 2024 draft update that involves HPV primary testing every 5 years as the preferred method. And this is something that has also been endorsed by the Women Preventative Services Initiative, which is closely aligned with ACOG. All that being said, for any abnormal testing results, we still reflex back to the ASCCP and their guideline algorithms for how to manage any abnormal testing results. So these trends of primary HPV testing have come from data that's been collected and published in many other countries, including Australia, New Zealand, Sweden, many other European nations. But it made me wonder, what studies are going on in the US that could be contributing to increased compliance rates and increased screening in our population. So the first trial that I looked at was called the Priestess trial. And this was a single-blinded, randomized controlled trial that was publicly funded in a safety net health clinic setting in southern Texas. And the primary goal of this study was to evaluate if mailed self-collection HPV testing kits could improve cervical cancer screening among underserved women in the safety net health system. And these results were published in JAMA in 2025. So again, the population were individuals in this safety net clinic. There was almost 2,500 women enrolled, and they were randomized into 3 groups. One that received a telephone call reminder letting them know, hey, you're overdue for screening. Another group that received a a kit mailed to their home to perform self-collection, and then a third group had an added benefit of a patient navigator to help them through this process. And the results I was pretty impressed by. You can see on the far left, that's just the telephone recall group, people that just got a notification that they were due. And that, led to a 17% completion rate of cancer screening within the first 6 months. However, you can see how that drastically increased by the rightmost column with the group that received at-home mail collection kits and a patient navigator. That group was 46, almost 47% completion rate. And I do just want to highlight that that was only 5% greater than the group that just received the mail-in kit without a patient navigator. And so I was super impressed by the results of these studies, and I think it definitely highlighted that self-collection can be a tool that's utilized to increase compliance rates, especially in those vulnerable populations. The few limitations I wanted to highlight of this study was it was a fairly small study, and I think a lot of that was due to some of the exclusion criteria. A lot of women needed to provide a permanent personal address to be able to participate, and that, I think, cut out a large number of individuals. Also, the self-swab that was used in this study is approved for clinician-collected samples at this time, but it does not have FDA approval for self-collection. So that's just the other thing I wanted to highlight. And then the follow-up on abnormal results in this study was about 65%. So women that did have positive HPV testing, of course, we'd love to see that number higher than 65% on their follow-up. However, I remind myself that this is a group of individuals who probably could have gone months, years, or decades without being screened otherwise, so had to keep that in mind. But this led me into thinking about what about other populations that maybe don't have as many barriers to care. And that led me to finding the STEP trial. And this was another randomized control trial, but it was conducted within Kaiser Permanente in Washington State. And it evaluated different outreach strategies that, again, offered mailed HPV self-sampling kits to see if it changed compliance rates among women that, for the most part, had less barriers and more access to care. And it was a much larger study. It was over 31,000 participants that were enrolled in this study, ages 30 to 64, who were either overdue for screening, due for screening, or had an unknown prior screening history. And from those groups of women, they were randomized into 4 arms due to logistics and appropriateness. And the results, again, demonstrated that even in women who were due for cervical cancer screening, meaning that they were previously compliant in all the years leading up to this, they still exhibited a significant improvement in screening compliance compared to the usual standard of care. So 61.7%, versus 47% in the control standard of care group. And then an even more impressive improvement in the group that was overdue for screening. They nearly doubled their compliance, between 18% for the routine standard of care and nearly 36% in women who were offered the option of doing a self-collection kit. And I will say on this study, not every woman who received the mailed-in kit did it at home. Some of them brought the sampling kit to the clinic and still had the clinician perform the sample collection. But I think it goes to show that women appreciate having options, and this still can increase compliance rates and provide more access to those who previously were hesitant. So I think that the STEP and Priestess trials proved that self-collection can improve compliance adherence with screening. But how do we know that these are results that are reliable and accurate and something that we can use confidently as a screening tool. And again, I mentioned briefly that data has been collected and published in several other countries, but I wanted to focus on what was going on here in the US. And this led me to finding the SHIP trial, or self-collection for HPV testing to improve cervical cancer prevention. And this trial is sponsored by the NIH's Division of Cancer Prevention. This trial has been conducted nationally across 25 different sites in the US, and they just recently stopped enrolling participants. But the objective of this trial is to determine whether self-collection vaginal specimens yield similar accuracy on HPV detection compared to clinician-collected cervical specimens. And the results are expected to provide robust US-based evidence on the performance of unsupervised at-home self-collection testing to help inform and provide future guideline recommendations for primary HPV-based cervical cancer screening. And essentially trying to determine if the image on the left, the self-collection swab, is as efficacious as all of these other more invasive cytology collection tools that have been used for decades. The results of this trial have not been published yet, but they're projecting publication sometime in 2027, so stay tuned for how this turns out. And in summary, I think that utilizing primary HPV testing is excellent. I think that it's something that we should all strive to incorporate into our practices for cervical cancer screening. And I definitely think that it's an incredible tool to increase access and screening options among vulnerable populations and those that are hesitant to Pap smears and other more invasive forms of cervical cancer screening. And so, yes, I do think that extinction could be on the horizon for invasive cervical cancer, certainly in my time practicing medicine. Thank you.
It's great to be here with you all. My name is Morgan Green, and I will be speaking about penicillin allergy delabeling at Porter Family Medicine Clinic. I'd like to thank the team before I get started, Dr. Hutchinson, Dustin Waters, Rebecca On. It really was a team effort. Couldn't have done this quality improvement project without them. This will be building on a poster presentation that I did last year on the same topic. We'll go over this data and the results from last year and talk about how we improve things this year. Just an outline, we'll go over background, impact of inappropriate penicillin allergies, what we can do to help, then we'll go into the details of our project, and then do a conclusion. Also, before I get started, just to let you guys know, I'll be joining a practice in Bristol, Tennessee, where I'm from. It is internal medicine and pediatrics, but they do have family medicine doctors, so that's what I'll be doing after graduation. No conflicts of interest to disclose. So penicillin allergy, as we all probably have seen in practice, is a widespread problem. It's the most commonly reported drug allergy in the US. 10% of all patients report a penicillin allergy. What's interesting is that 90% of those patients will not react to a penicillin type medicine if tested, like formally allergy tested. And this is not without repercussions. Penicillin allergies are associated with longer stays in the hospital, development of drug-resistant infections, excess healthcare costs, and increased mortality. This is a study that showed the increase in mortality. It was small at 6%, but was statistically significant. This is a fairly large study with over 1 million participants. So lots of negative impacts from penicillin allergies, and that's why it's important that we talk about what we can do to help. So removing unnecessary allergies or delabeling is a focus of antimicrobial stewardship programs all over the world, and specifically the American Academy of Allergy, Asthma, and Immunology and 2022 practice update, they recommended the following: that we proactively delabel penicillin allergies, and that direct oral challenge to penicillin is appropriate in adults with low-risk allergy histories. So you may be asking, how do we define what a low-risk allergy is? Some of that we probably know based on just the history and kind of our clinical understanding of what constitutes an allergy, but there is an objective, a more objective way to do this recently, and this PALACE trial in 2023 was kind of groundbreaking to show that there's a questionnaire called the PINFAST questionnaire, which we'll go over in just a second, that really allows us to objectively determine how high of a risk a patient's penicillin allergy is. So PINFAST is now a validated clinic decision tool. And this study also showed that those with a low-risk penicillin allergy based on a low PINFAST score are appropriate to go straight to oral amoxicillin challenge and can skip the previously standard of care, which was skin testing, like skin prick testing. There are situations where skin testing is still necessary, but before oral challenge, but with low PINFAST score, we can skip that step. Here's the PINFAST questionnaire. It's 5 questions. The first, of course, is the patient allergic to penicillin? And then it's a mnemonic fast, starting with the F, has it been 5 years or less since the reaction? And so if it has been that recent, then that would be 2 points. And the more points indicates a higher risk of true allergy. Then the A stands for did the patient experience anaphylaxis or angioedema? Of course, a history of that would increase our concern for a true allergy. The S is for severe skin reaction, like Stevens-Johnson syndrome or DRESS. And then the T stands for was any treatment required at all? And then you can see at the bottom kind of how to interpret the results. For our study, we decided that a score of 2 or less would be considered a low-risk score. So that score of 2 or less is 5% or less score of having a true allergy to penicillin. And just one more final stamp of approval before we get into the details of our study. The AAFP, American Academy of Family Physicians, of course, in 2024 said that it is within the scope of primary care clinics to administer oral amoxicillin challenge to low-risk individuals. And now we've talked about who is low risk as well. So getting into the details of our study over at Porter Clinic, our mission statement was to improve antimicrobial stewardship and the outcomes and health of our patients by removing unnecessary penicillin allergies. And then our goal, our aim statement was to delabel or test 20 patients by start of this month. So we'll get into our protocol last year from July 2024 to last April. And this is what my poster was on last year. So our protocol last year involved our clinic nurse going through all the patients at Porter Clinic who had been seen within the past 2 years and looking at their allergy list. And then she would reach out on the phone and she would administer the PINFAST questionnaire over the phone to all of those patients. Patients who scored 3 to 5, we wouldn't recommend amoxicillin challenge. But those who, like I previously mentioned, scored 0 to 2, we would recommend this. And in our protocol, this involved a single dose of oral amoxicillin, 500 milligrams. We would then monitor the patient for an hour. And if they did not develop a reaction, we would, of course, educate and inform the patient of what the meaning of being able to take penicillin family in the future. And then also we would call their pharmacy and remove it from the EMR. If they did develop symptoms of reaction, then we had treatment ready, like IM epinephrine and topical steroid and antihistamine. But as we'll see, thankfully, we've not had to do this yet. So now we'll get into our results. Starting with last year, we were able to screen 159 patients, and of those, 49 were willing to be screened. 39 were low risk on the PINFAST questionnaire. And then 15 were verbalized their willingness to be tested. Of those, 12 actually came in to be tested, and exciting, all 12 were negative tests. So it's great that we had 100% success rates, and that was great for those patients. But as we were looking at how to make this project better last year, the big way we were losing patients was between this initial step of those we contacted and those who agreed to undergo screening. So we went back to the drawing board and talked about our PDSA, or Plan, Do, Study, Act cycle, and thought of ways that we can improve participation. First, we tried the phone triage with no incentive, and that we had low participation as we saw. We actually added incentive, which was a meal voucher at McKayD's cafeteria, which I think is delicious, but it did not help participation very much. So then we moved on to our how to improve this project going forward this year. So we got a little pushback. I don't know, some of you guys may know that Porter Clinic moved from the hospital to just across the street here, just down the road. So that pushed back our start date a little bit, but we were able to start in February. And our new protocol this year, instead of the clinic nurse reaching out to people on the phone, she would look at the schedule for in the morning of patients coming into Porter Clinic, and she would then see those with a penicillin allergy and administer the PenFast questionnaire in person at that appointment, ideally at the beginning of the appointment before they saw the doctor. And then the rest of the protocol was the same. We just had the same cutoffs for PenFast. It was still a 500 milligram dose of amoxicillin, and we still had an hour of monitoring. So now we'll compare our data from last year to what we have so far this year. So far this year, we've been able to contact 29 patients. Of those, 27 have agreed to be screened. So we already see a quite a bit better participation rate, it looks like. 19 have been low risk PenFast score, and of those so far, 9 have voiced their willingness or interest to be screened, and so far 4 have undergone amoxicillin challenge. So this is a visualization of our improvement in participation so far. Last year, of all the patients that we contacted, 7.5% ultimately underwent amoxicillin challenge. This year, it's improved to 14%. But still not statistically significant, likely because of our small number of participation or participants so far this year. And the big drawback so far of our study has been participation, and this is just brainstorming some ideas as we continue to think of ways to improve this project, of why this may be. Of course, fear of allergic reaction is one we could all understand. The time requirement is kind of inherent, but this is an improvement of the two multi-step testing with skin prick testing, and then some protocols even have multiple doses of amoxicillin. And so it can be 2+ hours. Are still at an hour, that's still a lot of time, for the patient to contribute to this. And then the lack of awareness of benefit or the lack of immediate benefit, we could all probably understand it's hard to devote this much time to something that might not help you for years. And then entrenched beliefs is something that I think is true of patients, that they hold on to their allergy history, but also for us in the medical field, I think a lot of this data is pretty new, and so I think it starts with us to start to look critically at especially penicillin allergies and know of these adverse effects that are associated. So next steps, we've seen that introducing this screening in person at already scheduled visits is helping participation, but we still need some more time and data to see if this is significant improvement. And then our goal is for this challenge to be offered on the same day that the PenFast questionnaire is administered. Ideally, like I said, the questionnaire would be given at the beginning of the visit, and then the patient would actually receive, if appropriate, the amoxicillin challenge, and then they would undergo their appointment with their doctor, and then by that time, they would only have to wait around a little bit maybe at the end of the appointment to finish the challenge. So in conclusion, we've seen that PenFast is able to identify low-risk patients who are safe to undergo oral amoxicillin challenge. Our initial study, 100% of those who we challenged were successful. Participation continues to be a limitation, and we've already seen that it looks like increasing or introducing screening in already scheduled visits is increasing participation. Here are my references, and then we'll do questions in a little bit. But thank you all.
Okay. Hi, I'm Sydney, and I will be talking about hepatitis C and comparing primary care versus specialty care. no disclosures. Okay, so I wanted to start off with a story about a patient I had in clinic. He's about a 40-year-old male, has risk factors of IV drug use, incarceration, and has had known hepatitis C for about 20 years. And within that large time frame, has not been treated at all. And it's crazy to think that for 20 years with an infection that can be easily treated with a medication, and if not, lead to liver failure, cancer, and death, that we just have a wide time frame between detection and treatment. And unfortunately, this is a very common situation for many patients. So I wanted to just start off with briefly reviewing some Hep C basics. To detect hepatitis C, you get an antibody, and if that antibody is positive, that means the patient has been exposed to the virus. And so we need to determine if that virus is active. So we get a viral load. And then if that viral load is detectable, then we have a replicating virus in the blood, and we need treatment. And so treatment has changed over the years. Initially, it wasn't great. It required oral injection courses over a lengthy period of time, had high rates of side effects, and just didn't work. So we no longer use those. And now we use direct-acting antivirals. And they're 8 to 12-week course, oral pill, depending on which one you use, minimal side effects, and really great efficacy. So you would think with improved treatment options that we'd be making progress towards eliminating Hep C. Fortunately, no. The US Department of Health and Human Services, along with the World Health Organization, has created this massive goal to eliminate hepatitis C by 2030. And as you can see from the figure on the right, I'm not sure how it comes through, but the list of states are on the left, and then on the x-axis, there is the proportion of cleared viruses, or the proportion of Hep C cleared viruses. And on the top is great. That means we have increased cure rate. And as you go through to the bottom, that's less. And as that first vertical line, dashed line, it was the goal for 2025. So we are substantially behind that goal. Utah is unfortunately towards the bottom. And so why do we still have this large gap? Well, there are many factors that go into Hep C and why we're not where we should be. One that I want to focus on is the opioid epidemic and how that had led to increased IV drug use. And as you can see from the figure, between 20 and 40-year-olds had an increased cases of hepatitis C. And so with this population, they do have difficulty accessing care, and then that can delay treatment. And so we worked with Hope on Tap, an organization out in the community that does outreach for free point-of-care hepatitis C antibody testing in the community and targets these high-risk populations, people who recently just left jail and are trying to get their life back on track. And so we partnered with them in 2023 for a referral service, so they actually had somewhere where if their antibody was positive, they were able to get treatment. So in the community, Hope on Tap would get an antibody, and if that was positive, they would contact our clinic and refer to us for a visit and further labs. And if they were found to be infected, we would message Dr. Lyson, a GI doctor in our community, to get approval of whether we could treat or not. A common problem that we had with this is there were a lot of no-shows. These visits were in person and were usually weeks down the line of when they were initially tested. And so as my second year quality improvement project, I did an intervention to hopefully improve the number of patients coming to our clinic for treatment. And we offered video visits and/or walk-in visits to hopefully ease any transportation barriers and to allow them to be started hopefully on treatment quicker. And this had shown to be effective, and it has expanded our population where we can get them started on treatment from beyond the Ogden community. However, prior authorizations continue to be a problem in getting these medications approved, and they require a specialist approval, such as a GI doc. And while it's hard to get away from prior authorizations for these expensive medications, I wondered, with the treatment being so simplified and simple now, this should be something within primary care that is easily implemented. And I was wondering, is there a reason why, specialty still needs to be involved in some of these cases? And just to note, there are some cases Hep C should be treated by a specialist if they have cirrhosis, Hep B, and HIV co-infections. But these are the more simplified, they have Hep C infection with no other complications. And so that led me to, how do primary and specialty care physicians compare in hepatitis C treatment outcomes? And just to start off, there's not a lot of data comparing specifically primary care and specialty care in hepatitis C treatment outcomes. So just kind of take that into account. But I'm going to talk about these next two studies were included in a meta-analysis of comparing primary care and specialty care. There weren't a lot of studies in the meta-analysis, just around 9, and the sample sizes are pretty small. But the first one was a non-randomized clinical trial in 2018. And so this was a non-randomized trial and included 600 patients with Hep C across 13 federally qualified healthcare centers in District of Columbia. And so basically, their primary endpoint was to determine the efficacy of Hep C treatment via sustained viral response, which is testing after 12 weeks of treatment to determine if the virus is no longer detectable. And they wanted to compare across 3 provider types, NPs, PCPs, and specialists, using those new medications. And I just want to touch base on the non-randomized component. It's a little bit interesting on how they did that. So it first started off with the specialists choosing which patients they wanted to keep, and then the remaining were just divided among the NPs and PCPs. And so what they found was, on the left, you can see the providers are categorized into NPs, PCPs, and specialists, and then the data regarding the viral clearances on the right. And the overall sustained viral response rate for NPs was 90.4%. For PCPs, it was 87.6%, and then specialists is 84.8%. And so overall, these differences weren't significant, and it's showing that Hep C can be treated by primary care and achieve similar viral clearance rates as them. And then this next study also looks at viral clearance rates, but also looks at treatment uptake. And this was a randomized control trial done in Australia and New Zealand from 2015 to 2018. And the population consisted of people who inject drugs and have known Hep C infection without cirrhosis. And the objective was to compare, again, treatment initiation and viral clearance in primary care versus specialist care. And it had 140 participants, and they were randomly divided to primary care and standard of care, which is specialists. And you can see the eligibility did decrease within those. And within this study, there was a specific criteria to get a liver scan, like a fibro scan. And if they didn't do that, or they didn't meet eligibility criteria, then they dropped off. So that's why there's that difference there. And that is not always needed. So the results of that are shown on the screen. On the left represents standard of care, which is specialist. That's the red. On the right is blue, which is primary care. And you'll see the numbers. The first one is eligibility. The second one is starting the treatment, and then the last one is viral clearance. And so using intention to treat analysis, the proportion of participants starting treatment in the primary care arm was significantly higher than the standard of care, 75% versus 34%. And then the viral response, also using intention to treat analysis, had similar findings with primary care having higher viral clearance versus standard of care. And so these last two studies, although they have smaller sample sizes and more research would be beneficial, I think it's pretty promising that these studies demonstrate primary care can be very helpful in clearing the virus and also possibly getting more people started on treatment, especially in these high-risk individuals. And just briefly to touch on another project of where primary care can be effective is this was a study part of the National Institute of Health funded Rural Opioid Initiative and was conducted in rural counties in New Hampshire and Vermont. And so it was a randomized clinical control trial, and it compared mobile telemedicine care to enhanced usual care, which again is referral to a specialist. And it was, again, in rural counties, and it was conducted from 2022 to 2024. And the outcomes were, again, to look at the proportion of participants initiated on treatment, and then, again, the viral clearance at 12 weeks. And so, like previous studies, this shows good data regarding where mobile telemedicine and primary care's impact can be had. Again, the number of treatment was higher with mobile telemedicine, and again, higher with viral clearance. And this is another area where primary care is evident in rural areas where specialists are not available and how we can be impactful. So, the goal to eliminate Hep C by 2030 is a huge goal that will be difficult to carry out without the help of primary care. And yet barriers do exist despite evidence showing primary care can have similar efficacy in treating the virus and can also help expand treatment initiation to high-risk population in rural areas. And so Hep C is in the scope of primary care. And I do see things where people will say refer to GI for Hep C infection. And I just want you to rethink that when you get a patient with Hep C infection does this need to be referred to a specialist or can I take care of it itself? And if you don't want to take care of it yourself, there are many other primary care providers in the community that would be happy to take on that patient. And just to close out, so I mentioned Hope on Tap, and Steffi Perry is an outreach coordinator for Hope on Tap that we work very closely with. And she has come to our residency and talked about the impact treatment have on the patients she sends to us. So I just want to share a quick message. She said, "I've seen so many people cured of Hep C, something many of us contracted during periods of our lives filled with trauma, survival, shame, addiction, and pain. And when that shame starts getting removed, healing starts happening far beyond just the physical body. We start taking control of our health again. We start believing we deserve care again. We begin taking care of ourselves better. We show up differently for the people around us. We help others heal too." And that's all.
Good morning. My name is Rachel Haynes. I'm sorry I couldn't be with you today. My oldest son is graduating from college in Tucson, Arizona, and I wanted to be able to support him today at that event, but I will be talking about nutrition and lifestyle education and medical training. I have no disclosures. I want to start by telling you about a patient of mine. We will refer to him as MR for reference. MR is a 59-year-old male. He's got a past history of alcoholic cirrhosis and methamphetamine abuse. He showed up in clinic, this was about a year ago, was not feeling well. Some labs were done and it was quickly discovered that he had new onset type 2 diabetes. His A1C was 10.5. So I want you to think about this patient with his background of cirrhosis and meth use. Is it worth taking time to counsel a patient with this background? Well, initially he was started on metformin and a GLP, and I took some time to give him some lifestyle counseling as well. We talked about eliminating soda and starting an exercise program and increasing his intake of fruits and vegetables and high fiber foods. And then I began to meet with him intermittently over a period of a year. Sometimes he would show up for visits, sometimes he wouldn't, but his A1C began to decline. And it began to decline even though he wasn't very adherent to his medications. Sometimes he would take the metformin, some weeks he would take the GLP injection, other times he didn't. But at my most recent visit with him in March 2026, his A1C was checked and it was found to be 6.4, down from the original 10.5, and this was 6.4 without using any metformin, without using any GLPs. And he was regularly exercising, he had cut soda out of his diet, and was trying to do a better job eating whole foods. So that leads me into the focus of my talk, which is nutrition education in medical training. And there was a great paper that was published in Circulation 2018, which took survey data from several different sources, surveys that were done between 2000 and 2013, and it synthesized these survey data all together to provide some recommendations about nutrition education in America. One of the things that this paper discussed was that the average number of hours of nutrition education in medical training has declined. The recommended minimum amount is 25 hours, but it is typically only around 19 hours. And 71% of medical schools provide less than that recommended 25 hours of nutrition education. And when they surveyed directors of family medicine, internal medicine, and anesthesiology, and this was 495 directors of these programs, they found that only 26% offered formal education in nutrition training. In addition, survey data from internal medicine residents and family medicine residents was obtained, and they found that only 14% of these residents felt confident in their ability to provide education about diet to patients. Why is this important? Well, we can't expect doctors to provide nutritional education when they have never received it and don't feel confident in it. I graduated about 30 years ago with my undergraduate degree as a registered dietitian, and I also have been a certified group fitness instructor for over 30 years. I've long recognized the importance of lifestyle and nutrition and health. And really what I want you to understand is that research backs that up as well. When I initially graduated, a lot of the old school physicians didn't feel that nutrition made any difference in somebody's current health status. We've really seen that belief be reversed over the last several decades, which is awesome. But research shows that too, that nutrition education makes a difference. One of the studies that I looked at was published in 2024 by Ganti and others, and it outlined a large academic medical facility that took their residents, their internal medicine residents, and they provided them with a lecture, a small group discussion, and a skills exercise. And then they did a survey before and after to see what their confidence was in providing nutrition education. And it increased from 27.5% to 87.5% after this intervention. One of the other studies I looked at was published in JAMA in July 2022, and this was USPSTF Evidence Report and Systematic Review. And they found that patients that received nutrition counseling, their outcomes improved as well. And this was dose dependent. And what I mean by that was the more education these patients received, the better their outcomes were. And those outcomes included things like their LDL measurements, their adiposity measurements like waist circumference, BMI, blood pressure, all of those things improved with lifestyle counseling. So my goal was to improve the confidence of the residents of the McCady Family Medicine Residency Program in their ability to provide lifestyle or nutrition counseling to patients. I chose 2 specific areas to focus on. That included metabolic health, and you can see some of the subtopics listed here. And that also included immune and inflammation. And you can see the two subtopics here. And before I get into the nitty-gritty of my research, I wanted to talk about the recent evolution of nutrition education in the US just over the last few years. In 2021, there was a bipartisan House resolution that medical nutrition education needed to be expanded. Yay, something that Republicans and Democrats both agree on. Doesn't happen very often. Because of that bipartisan House resolution, a committee between the ACGME, the AAMC, and the AACOM met together and had a summit. And after multiple meetings between these three groups, in 2026, the Department of Health and Human Services released an initiative. And in this initiative, they outlined that there are now mandatory requirements for residency and fellowship accreditation that include nutrition education, starting in 2026. So far, more than 50 medical schools have committed to increasing nutrition training from 25 hours to 40 hours. And they are in the process still of outlining what these nutrition competencies will be. But right now they have 71 potential nutrition competencies outlined. Focus of my study was that I would take the McCady Family Medicine residents. I would provide a lecture on lifestyle medicine, specifically on metabolic health, and also on immune and inflammation and things that can influence both of those areas. The residents would receive a pre-test, then they would listen to a lecture on those topics, and then 2 months later I provided a post-test questionnaire to again assess their confidence in those areas. I know you can't read this. This was just an example of the survey that I gave. For each question, there was a Likert scale from 1 to 5, 1 being strongly disagree and 5 being strongly agree. Now I want to get into the results of my study. So these are the results of the pre-test that was given prior to attending my lecture. This data won't make a lot of sense right now. Give me a minute and we'll get to the final results. I did want to show the range of information. So on the bottom, on the x-axis, each of those numbers represents a question on the questionnaire. The y-axis represents that Likert scale. Again, 1 was strongly disagree, 5 was strongly agree. And you can see the range of responses for each question. And then the green circles represent what the average response was for that question. So here are the post-test results. You can see that the average is increased and also the range of responses has decreased as well. And now the moneymaker, this is the slide that shows the pre-test and the post-test answer for each question. Again, on the x-axis, each number represents a different question on the post-test and pre-test. The green represents the pre-test value, and the higher the column, the more confident residents felt. The orange column represents the post-test answer for the question. And we don't have time to go into all of the questions, but I did want to give an example of 3 of the questions that I asked. So one of the questions was, I know the criteria for diagnosing metabolic syndrome. Again, green is the pre-test, orange is the post-test, and you can see the elevation in the post-test score. Another question, I feel comfortable ordering and interpreting labs related to metabolic syndrome. Again, note the post-test has a higher response, more confidence. And the third question I'll share is, I can identify common comorbidities associated with metabolic syndrome. So these were some of the sample questions. So my conclusions from this study is that nutrition and lifestyle medicine teaching does improve resident confidence. People feel more confident in providing this information to patients when they've had some education regarding it. What are some of the limitations? Well, medical school is busy. Residency is very busy. So I think some of the biggest limitations will be how can we fit this in to an already busy curriculum, both in medical school and in residency, with didactics. But really what I want everybody to walk away from this with is the belief that counseling patients makes a difference. It makes a difference in the lives of those patients. That patient I talked about at the beginning with this history of cirrhosis and methamphetamine abuse, that had an A1C that went from 10.5 to 6.4, it made a difference for that patient. And he responded to that counseling that was repeated over several visits. So making the effort is important. And lastly, I just wanted to share what's next for me. I am excited to join the Intermountain Health Layton Family Medicine Clinic, which is just off of Antelope Drive. This is a great group of physicians, many I've worked with over the last 3 years as a resident. And now I get to join their ranks as an attending and continue to work with the residents both in clinic and on the family medicine service. And my references.
All right, we're going to have our first speakers join us here. Dr. Haynes is trying to join us remotely as well, so you can ask her questions about her project. We have time for several questions, and then we'll hear from our second half of our group. Looks like we do have Dr. Haynes on with us. If you have a question, please step up to the microphone and let's hear. While they're, oh, perfect.
This is for Dr. Haynes. While I was listening to you talk about how to integrate nutrition into medical school education, I had an idea that if you could couch it in terms of the student's health himself or herself, then you can say, well, if it's good for me, maybe I could use this for my patients. A lot of medical students, while they're extraordinarily busy, they do like to hear ideas about their own health, and that might be one of the ways it could be integrated.
Thanks to all of you for your presentations. Sorry, did you want to respond?
Dr. Haynes, did you have a response to that? So we don't look like we have sound yet, so. Go ahead and try again. All right, well, we'll work on that. Go ahead and Dr. Andine, ask your question. We'll circle back around to that.
Thanks to all of you. These are really great presentations, and it's fun to hear about what you guys are doing in the residency these days. I took particular interest in Morgan's presentation because, perhaps somewhat biased, I have my own sort of lingering childhood penicillin allergy following me around everywhere, and based on your PenFast, I thought, I think I'm probably low risk. I wonder, and I'm impressed with the protocol you guys have developed and implemented at Porter. Are there plans to sustain that going forward for all patients at Porter who check in and have a penicillin allergy?
Yes, there are. Another resident, actually, who's a current second year, is planning on continuing this after I leave, and so hopefully we can keep it going for as long as possible, continue to figure out ways to make it better and delabel as many patients as possible.
Question for Savannah. So HPV testing. So you mentioned about home collection, which is not FDA approved, and then the clinician collected, which is HPV, or excuse me, which is approved by the FDA. There's a third option too, and that is actually patient self-collection in the clinic. I mean, we do that with what used to be called the AFFIRM test, the vaginal pathogens PCR test for BV and Candida and Trichomonas. So did you see anything that distinguished that, the self-collection in the clinic idea as opposed to at home? Because that would capture an additional number of patients too.
Yeah, thank you for bringing that up. For the sake of time, I didn't get too much into the weeds on that, but yes, this second trial that I talked about, the STEP trial, in the discussion of that paper, yes, it did kind of delineate a subset of people who had samples collected in the clinic versus at home and then mailed it in. Just for the sake of time, I didn't get into that, but it did still show increased compliance rates for updating their screening, and for our current standard of care, we're adequate test results. But yes, that is another good distinction. So thanks, Dr. Johnson.
I have a question, I think it's Sydney, with the patients who have been treated for Hep C and then clear their viral load. If they continue that high-risk behavior, they are at risk, am I correct, to develop it again?
Yeah, they are at risk. And so, like I said, with curing Hep C, there are a lot of efforts in addition to just getting them started on treatment. It's also targeting the activities itself, the IV drug use. And so there have been studies also reporting having treatment in conjunction with like opioid treatment, substance use clinics, and how that is even more beneficial, and then sterile syringe programs. But yes, they are at risk. So we do recommend kind of a very broad approach to covering all that. But I just want to make a note, if they are using IV drug use, it is not an indication to not treat.
Say that again, Dr. Schmidt.
So if they are using IV drugs, they are still eligible for treatment.
Okay, interesting. Thanks, excellent presentations. Dr. Cox, Doctora, we're in the process down at the clinic trying to move to a new paradigm to do HPV collection instead of Pap smears. But one of the things that I'm still questioning is, and I was wondering if any of the studies that you looked at the number of inadequate samples from self-collection.
Yeah, both trials included that data. They were fairly small percentages. I don't have them off the top of my head, but they were in the single digits. Okay. A lot of them were less than like 5% or less of inadequate samples. And I believe in both studies, they were still contacted and provided the opportunity to reperform testing. But overall, yeah, it does happen, but not as often as you'd think.
Good. Thank you. Jake, I'm going to throw one more at Dr. Schmidt. Genotyping used to be the big barrier for us to treat hepatitis C in primary care. Can you comment on that at all?
So genotype, because I think there's 6 genotypes, and so those oral medications, the direct-acting antivirals, are approved for all those genotypes. We do get the genotype still with our testing, but those medications cover all genotypes.
Excellent presentations, guys. Thanks for covering those topics. I had a question for Dr. Schmidt and Dr. Cox. Dr. Cox, first off, thank you for talking about this cervical cancer. It's near and dear to my heart. My sister-in-law actually she was one of those statistics and died from cervical cancer this year. And so it's really important that we eliminate this disease. One important part, though, other than the increasing detection, is vaccines and prevention as well, too. And I know you probably didn't have time to talk about this and such, but is there, could you kind of, did you do any like research with that at all, or kind of like, my concern is like the current vaccine hesitancy and uptake, and I think that's a big barrier towards eliminating this disease, in addition to detection as well.
Yeah, absolutely. And actually, when I first was compiling my presentation, I went into the weeds and looked mainly at HPV vaccination, and then realized it was going to be a much broader scope than a 10 to 12 minute topic conversation. So I kind of switched gears. But yes, I totally agree with you. I think HPV vaccination is going to be playing a huge role in hopefully the decreasing rates of cervical cancer. And I think it's something that we just really need to continue to stress the importance of all of us that see adolescents really, do the counseling, answer the questions, and let people know that this is an incredibly efficacious, safe, cancer-preventing vaccine.
You can blame me. I told her to trim it down, so.
I saved the slides though, so if you ever want to chat more about it, I'd love to.
I just wanted to give you an opportunity to give a plug for that too as well. And then Dr. Schmidt as well. One thing that I feel like we've kind of gotten into a little bit of a habit with in primary care is screening for hepatitis C in our patients, just kind of like a one-time screening. That's part of the recommendations and everything like that. In my practice, I've been doing that over the years. I tell my patients, I'm like, I'm never surprised by these results. I've never been surprised. There's a patient that I'm like, okay, yeah, you're going to be positive. You use IV drugs, But then the patients who have never done any of that, they're always negative, of course. Like, I'm just looking at, I wonder if did you come across any studies looking at the cost benefit of that versus like more of the like the targeted approaches, looking for the people in the community that are using IV drugs and looking at that rather than just doing like a broad swath of screening of everybody who, I mean, I know we don't want to be judgmental, but like the cost of that has got to be enormous, the differences there.
Yeah, that's a very good question, Dr. Saunders. I did not look into that regarding the cost analysis. But yeah, I'm not, and I don't know how it would compare to like community screening versus clinic, but that is a good question, and I should look into that.
Thank you.
Well, that was awesome. I expect the next three to be equally awesome. But a quick question for Sydney. So you alluded to the challenge, the barrier that specialty permission to use these drugs is required. Do you have any idea of what the changes may be ahead for that?
Yeah, I briefly just checked to see if there was anything going on in terms of legislature. I was talking to like one of the medication reps this past week, and Utah is one of the, I think, the few states that still require the prior auths to be approved like by GI. I think there is progress hoping to eliminate that soon, but I do not know the specifics.
Thank you. Let's see, do we have Dr. Haynes available? We'll see if we can, what we can do for the second half, but she did have her email up on her slides, which are available, and she has expressed to me that she would be very interested in taking any of your questions directly via email. Just the final question from me, I had a question for Dr. Green. You maybe briefly brief, offline you'd mentioned a similar effort that's happening in the hospital to try to delabel. Can you speak to what that effort is?
Yeah, so that's Dustin Waters, the PharmD, who also helped us with our outpatient version. And the inpatient, I actually think they're offering amoxicillin challenge to patients even up to a PINFAST score of 3, so a little higher risk because they're in the hospital and have a higher acuity of care available if necessary. But so far they've delabeled, I believe, 150 some patients. I think they've had only 2 true allergic reactions that, of course, responded very well to treatment. So it's becoming just more of a thing all over the country. But yeah, it is the inpatient version of our study has been pretty cool over at McKay so far. So
thank you. All right, well, thank you. Let's thank our first 4 speakers, and we'll continue with our second half right away.